I have the honor to invite the next speaker. He doesn't require any introduction. He is the founder of neonatal medicine in Pakistan Armed Forces, and he is a teacher of all neonatologists serving in Pakistan Armed Forces. He served as a professor of pediatrics and vital in pediatrics, Pakistan Armed Forces, principal Army Medical College, and principal Fazaya Medical College. He is a visiting professor of neonatal medicine, Military Hospital, Rawalpindi, and I mean General Salman Ali.
Bismillahir Rahmanir Rahim. I would like to first of all thank the organizers for inviting me to this August gathering and speaking before you. But as earlier Professor Syed Maqbool said that it's very hard to talk after so many giants have spoken. So I am the last one to wilt under the pressure of the three giants. So it will be very difficult for me to speak. But anyway, some of what I speak might be repetition. But you know, the many questions have been raised, as many have been answered by the previous presentations. And after listening to the presentations and seeing the state of the newborns in our country, I am just remembering what Allama Iqbal said. He said, "Paschi boyat kad ay aqwam sharq." Oh, nations of the East, what can we do? So that question again remains for the newborns of this country, and that question remains relevant for the neonatal sepsis also. So the question is what to do. Allama Iqbal answers this question in his Persian verse. He says, "Khezu janu naubide har zinda ra az qume khud zinda tar kun zinda ra." That means, please rise and give a new life to this half-living person. And with your own breath of life, please rejuvenate this dying human being. So I think we have to follow this second dictum and rise to the occasion. I think many of what has been discussed is just a repetition, and the mortality in our country has been, of course, very well highlighted. Just to add that the estimated economic burden of neonatal sepsis in low middle income countries has been estimated to be around $469 billion. So the economic cost is also enormous, while the mortality definitely is there. And the current neonatal mortality rate has been mentioned already, is more than 40 in this country. And the target of achieving the SDG would be very difficult if we don't address the top cause of neonatal mortality, which is sepsis. And in the under 5 age group, it has been found that 2 out of 3 sepsis cases in the under 5 age group is a neonate. And the incidences have already been mentioned, so therefore I won't repeat them. And these are also the statistics for the low and middle income countries, including Pakistan. And you know, one of the important thing is that those who suffer from neonatal sepsis are more likely to have adverse neurodevelopmental outcomes in the long term. And its economic and social costs have to be also addressed. Like already Professor Haq has told you that there are more than 121 definitions. So whatever definition you follow, the main thing is that sepsis presents as a sick neonate. So most neonates you will see are sick looking, but not all sick neonates suffer from sepsis. So therefore, the important thing is the challenge for the clinician is to establish whether the baby is having sepsis or some other serious affliction, because so many other serious illnesses in the newborn would mimic sepsis. And that is why if you visit any neonatal intensive care unit, you will see there is hardly any neonate who is not receiving an antibiotic, whether it's sepsis is diagnosed or not diagnosed. Even if there is some other diagnosis, people are administering antibiotics with the suspicion and fear of sepsis. So many neonates, they receive antibiotics not only for sepsis, but if there is a fear of sepsis, they receive an antibiotic. And you know, there are so many, there's a big list of conditions which can present where you would suspect sepsis. Inborn errors of metabolism, congenital adrenal hyperplasia, critical congenital heart disease, and immune deficiency, recently COVID-19. You see, all these conditions, they present with sepsis-like conditions. And even we have seen neonatal malaria mimicking sepsis. And we have also seen neonatal tuberculosis being referred as sepsis. And of course, other congenital infections and intracranial hemorrhages, you can suspect sepsis, you know. So early onset sepsis and late onset sepsis, that is a classification which is followed. So generally we say within 72 hours, presenting neonates presenting within 72 hours is early onset sepsis, and after 72 hours, it's late onset. But the CDC extends the definition to 7 days and confines to 72 hours the sepsis in babies who are very low birth weight and they have got they are being cared for in the neonatal unit right from birth, you know. So these are the Western figures, and there you see as the birth weight and gestation goes down, so the sepsis rate increases. And already since it has been mentioned about the common organisms, group B streptococcus is common in the West, followed by gram-negative bacteria. And for late onset sepsis, it is the, again, the gram-negatives and the streptococci. And in developing countries, generally both in the early onset and late onset types, the predominant organisms are gram-negative organisms. And as it was already mentioned by Professor Butta and Professor Haq. And I think what we need to learn from the West is how they have controlled the sepsis from group B streptococcus with proper screening of the mothers and peripartum antibiotic prophylaxis. Risk factors have already been mentioned, so I won't go into the details. But of course, prematurity, low birth weight, and prolonged rupture of membranes, maternal choriamnitis are major risk factors for early onset sepsis. And for late onset sepsis, again, prematurity, low birth weight, socioeconomic status, and lack of hand washing has already been mentioned. And one of the important thing is bottle feeding, which again, we need to emphasize. The importance of breastfeeding as a protective factor has already been mentioned by the previous speakers. Then healthcare associated practices. So we have to improve those to reduce the incidence of neonatal sepsis. And invasive procedures in the NICU, prolonged hospital stay, and use of antimicrobial agents with development of resistant organisms. As Talal pointed out, that cephalosporins increase the risk of NEC. The clinical features, again, are systemic. So you will find the clinical features of sepsis almost in all the systems. Mainly, you have to find whether the temperature irregularity, whether it's high temperature or hypothermia, behavior change, poor feeding, and skin signs because of vascular changes and the cardiopulmonary features. Apneic spells, metabolic findings include hyperglycemia and hyponatremia, and similarly signs of focal infections, and very important not to miss meningitis, which may accompany particularly late onset sepsis. So as symptoms and signs of sepsis are non-specific, so non-infectious causes also enter into the differential diagnosis. So you would need some investigation to support your diagnosis. So complete blood count and DLC blood cultures are important before you start empiric antibiotic therapy. Blood cultures should be taken, and lumbar puncture if you suspect meningitis, and if the patient is otherwise low birth weight and very sick, safer to do lumbar puncture rather than taking chances. And as Professor Huck pointed out, molecular testing, which is expensive and not available in this country, but they have improved the diagnostic accuracy of neonatal sepsis. A chest X-ray might be indicated, and urine examination in selective cases where you suspect urinary tract infection. Now, the IT ratio is very important. If it's more than 0.2, supports sepsis. Thrombocytopenia. CRP is commonly used in the neonatal units. So a single CRP will be of no use. So you have to go for serial CRPs to monitor the infection and the need to administer antibiotics. So if the CRP doesn't rise, say, in 48 to 72 hours, so you can stop the antibiotic. Similarly, procalcitonin is another acute phase reactant, which rises earlier than CRP, and you can suspect diagnosis earlier. And cytokines, neutrophil surface antigens, and presepsin, these are markers which generally are not available here. Very important that we examine the placenta and fetal membranes for chorioamnionitis. And generally there are very few people I've seen who examine the placenta and the fetal membranes. If I attend a delivery in an obstetric unit, I make it a point that when I examine and resuscitate the newborn, so I would ask the obstetrician to show me the placenta. And many times where we have suspected chorioamnionitis, or the neonate appears sick, or the neonate appears having IUGR, so I always send the placenta for histopathological examination. So it is the fetoplacental unit, you have to examine. So if you examine the newborn but miss the placenta, you are not examining the newborn as part of the fetoplacental unit. Well, there are risk assessments. I mean, many times baby is born, so you would try to find out whether this baby is at risk of sepsis, whether antibiotics should be started. And since the early onset infection is related to maternal transmission of organisms, so you have to take into consideration whether the mother is having fever or she has had rupture of the membranes. There is a neonatal early onset sepsis calculator available as web-based, and you can calculate the risk of early onset neonatal sepsis. This is particularly related to group B streptococcus. So that is why this also helps in the diagnosis. And you can also have serial clinical examination to find whether the baby is actually having sepsis or not. So it's very important that the neonatologist examines the neonate serially to not to miss these signs of sepsis. And it has been found and compared with other risk calculators. Clinical examination has been found, if done carefully, to be better than other parameters. So for third world countries, careful clinical examination, clinical expertise is very, very important, because we are less dependent upon investigation. We have to be more dependent upon our clinical expertise. Another question is, now, if you have made a diagnosis of sepsis, what should be the empiric antibiotic therapy? As already Professor Haq showed, that if you delay antibiotic therapy, so you are going to increase the mortality. Like the golden hour for neonatal resuscitation, you have got a golden hour for starting treatment for neonatal sepsis. The longer you delay, you are putting the baby at risk. So therefore, you should be very, very vigilant, and you should have your protocol set as what to start at the time of suspecting neonatal sepsis. So the general recommendation is to start the penicillin or ampicillin with gentamicin or amikacin, but you have to consider your local sensitivity patterns and devise your institutional policies accordingly. What is your resistant pattern in your unit? And once culture results are available, you modify antimicrobial therapy accordingly. Now, multi-resistant gram-negative organisms are a problem in most neonatal units in Pakistan. And resistance to first-line antibiotics ranges from 70 to 100% in most reports and published studies. And outbreaks of sepsis in neonatal units due to gram-negative resistant organisms and MRSA are also commonly reported. As Professor Talal just pointed out, that he is encountering resistant Acinetobacter baumannii. And the question is, these resistant this Acinetobacter baumannii, this is a worldwide problem. Recently, we listened to papers at the European Pediatric Conference Infectious Diseases. So they also brought this problem of resistant Acinetobacter causing problems. And the other thing is that this antimicrobial resistance is, of course, now a global problem, and it is estimated to become the top cause of mortality by 2050, according to WHO. And WHO has actually declared antimicrobial resistance as the third biggest threat to human life, the first two being war and famine. So therefore, we have to be very careful in the rational use of antibiotics. Antibiotic stewardship program, as emphasized by Professor Haq, we have to follow that. And treatment should be for the appropriate duration for sepsis and meningitis. And I won't repeat the durations. They've been already pointed out by Professor Haq. And treatment of complications, including septic shock, DIC, metabolic complications, CNS and hematological complications, including meningitis. They are part of the management of neonatal sepsis. It's very important to look for underlying factors which predispose to sepsis. Many times you find a neonate who has got culture positive E. coli sepsis, and you are happy that you have found out the cause and you are treating E. coli, but the patient has progressive jaundice, does not improve. And when you do the metabolic investigations, you find that it's got reducing substance in the urine, and the baby is having actually galactosemia. So that predisposes. So you should look beyond neonatal sepsis. Do not get satisfied or complacent once you get a culture positive sepsis in a neonate. The question is, if the neonate is deteriorating, there might be something more than sepsis. So please look for it. And underlying, many times we have found underlying inborn errors of metabolism, like organic acidemia. And inborn errors of metabolism, again, are quite common in our newborns, which are commonly overlooked and treated as sepsis. So please look for underlying inborn errors of metabolism. These are also challenges to diagnosis. And many times these mortality is attributed to sepsis every time. No. And neonates with immune deficiency disorder, very important. If babies are dying of neonatal sepsis, and the parents give you the history that previous two siblings also died of neonatal sepsis in the neonatal period, so you should very strongly suspect that this is having some inborn error of metabolism or a genetic condition. In fact, we had a similar neonate in our unit who had life-threatening sepsis. And the mother was not breastfeeding, they had stopped breastfeeding. So we said, why did you stop breastfeeding? It's so protective. And the parents said, our two previous babies have died. They were breastfed, and we think that the breast milk of this mother is poisonous. So that is why we have stopped. So when we investigated, the baby had severe combined immunodeficiency on lymphocyte subset studies. So therefore, the diagnosis of severe combined immunodeficiency was made after two babies had died previously and a third one coming. So this is a big cost for a diagnosis, that previous two babies have died and you are diagnosing the condition in the third baby who is on the verge of death again. So it's very important not to miss underlying comorbidities and complications. And we have got a very high rate of consanguinity. So the clinician has to keep his or her mind open, you know. Now about other than antibiotics, supportive therapy has already been mentioned by Professor Huck. And supportive therapy may include not only cardiovascular support, but maybe you may need to infuse blood products also. Breastfeeding in all studies has been consistently found to be the most important protective factor. And there should be no compromise on breastfeeding. And as Professor Huck pointed out, sick babies need more calories. So please do not put them NPO. Because whenever we go to any neonatal unit, you attend a call and the first thing your junior says is, sir, I've kept the baby NPO and I am giving IV. So therefore, NPO really, it does not benefit the baby. Please continue breastfeeding. And here I would rather give you the example of a gynecologist who brought her baby with NEC from a peripheral hospital to a military hospital, combined military hospital, Rawalpindi. So the baby was referred to the pediatric surgeon for gut perforation, and the baby had IUGR. The baby weighed under 2 kilograms and visible gas free gas was there in the peritoneum. So the pediatric surgeon sent me a call. He said, sir, this baby is very sick. He looks very lethargic, septic. So if I operate, so the baby is going to, I suspect the baby won't survive. The anesthetist came and saw, and he declared unfit for anesthesia. In army terminology, it's unfit for anesthesia. So the question was left to the poor neonatologist, now what to do? The surgeon has refused to open. The baby has got NEC, has signs of sepsis. The anesthetist refuses to administer anesthesia, and you are left with a perforated gut. What to do? So what I did is I started the antibiotic protocol, and the abdomen was not much distended. So what I instructed the mother is, I said, you please continue your breastfeeding. And because with perforated gut, nobody would feed the baby. This was something against the book, against the teaching. So I said, you continue your breastfeeding. If the baby is not getting a distended abdomen, so you don't need to worry. So whatever distension is there, so this gut perforation might seal on its own. So if the air is not increasing, we don't need to intervene. And the mother herself, being a gynecologist, she continued the breastfeeding. We kept the baby for 2 months. The pediatric surgeon monitored the baby, and after 10 days, the baby started passing stools, wind, and at 2 months, the baby went home on breastfeeding. And the mother, being a gynecologist, she continued to feed the baby for 3 years because she was so much convinced of the advantages. And I told her the baby would be very intelligent. So 1 week ago, she called me and said, I am the same mother, and my child has got admission into the medical college, and he's second in merit. So you asked me to breastfeed for 2 years. I fed him for 3 years. Now I am thinking if I had fed for 4 years, he would have stood first. So, I mean, these are some of the things you can treat these conditions, many conditions with breastfeeding. So there are many other examples, but being shortage of time, so I won't go into that. Lactoferrin has already been mentioned. The role of probiotics, prebiotics, small role. IVIG and GCSF, as said, have no definite role, questionable. So the other important thing is we in Pakistan get a subset of neonates where the mothers refuse admission for neonatal sepsis. You think the sepsis is very important to be treated, but the mother is refusing admission, or they are not affording admission, or they are saying from a very long journey and we are 200 kilometers away, so we can't get admitted in your city, what to do? So here comes the community management of neonatal sepsis, including home antibiotic therapy. And according to one study, home antibiotics alone have reduced case fatalities by 35%. That means if you can't admit, if they are going home, please do not give up. Give home antibiotics, and as Professor Butta said, community management of these neonates, it reduces neonatal mortality. At least you can save some of these babies. So therefore, don't give up even if the baby is not getting admitted. And breastfeeding, of course, is an important component of home therapy for neonatal sepsis. Now, what are the future developments for neonatal sepsis worldwide? They are working on vaccines against the microbes which cause neonatal sepsis, monoclonal antibodies against the microbes causing neonatal sepsis. Then the mediators of neonatal sepsis, you can give the inhibitors like endotoxins, cytokine inhibitors, neutrophil adhesion inhibitors. And the other important thing is now the application of artificial intelligence in the diagnosis and management of neonatal sepsis. So this is coming in a big way now, artificial intelligence. And the other thing is application of nanotechnology in combating antimicrobial resistance. So what Professor Talal pointed out, the multi-resistant Acinetobacter. So there is a paper on this where they have used nanotechnology to counter these bugs, and it's very successful in vivo, but still yet to be licensed for patients. So that is a future dimension which is coming up. And prevention of neonatal sepsis is the key for us. It has already been pointed out by previous speakers, both in the hospital, in the community, safe delivery practices, and hand hygiene. Hand hygiene, we have seen, you visit any neonatal unit, the doctor is practicing hand hygiene. The nurse is just washing her hand once, and then she is sitting on the nursing station, doesn't walk to the basin to wash, just she might be doing the using the sanitizer. So with COVID-19, I think the sanitizer are now common. And the other thing, the other handlers are not taken into consideration. The AYA, the sanitary workers, you see, nobody is monitoring whether these handlers are washing their hands or not. So washing hands would be successful if all the staff, right from the sanitary worker, the AYA, and the family members, they wash their hands. It's not only the doctor. So we always emphasize upon our trainees, please remove your rings and gear up your sleeves, and they are following it. But the rest of the staff, I think there has to be somebody, a commander type person who should enforce it strictly on all the staff in the neonatal unit. Now, the prognosis in developed countries also, there is significant mortality, but in developing countries, definitely the mortality is unacceptably high. And what is the way forward? Neonatal sepsis, with its high mortality in developing countries, of course, constitutes a major threat to newborns. It's high time now that while we continue to highlight the problems for neonatal health, we need to shift our focus to identify the solutions and appropriate actions in this regard. And there is a need to form a task force of the PPA to devise national guidelines on all aspects of neonatal sepsis, including management at hospital and community levels. And I think Professor Syed Maqbool has pointed out this in his nice lecture, and I would second that. And a major focus on preventive measures, including the hand hygiene, breastfeeding, is very important. And this will go a long way in reducing neonatal mortality. And I think we should learn from our experience of combating COVID-19, using masks and using hand sanitizers, hand washing. I think this has reduced generally, not only we have prevented COVID, but we have prevented other respiratory infections from which we usually suffered seasonally, so this has helped. And I think this should help in the neonatal sepsis, prevention of neonatal sepsis also. So we are already trained on those lines. So improvement of clinic and laboratory services and task-specific training of health workers is the need of the hour. And there is a gross deficiency of neonatal units, as well as neonatal medical and nursing personnel who are not sufficient to meet the increasing neonatal load of patients in this country. And this needs to be addressed. So you need more neonatal units. You see, I mean, in medical colleges and major teaching hospitals, you see there are 5 or 6 medical units or 7 surgical units, but there is only 1 pediatric unit and a neonatal unit being a small component of that. So I think we need, at least in the first place, to increase the number of pediatric units. They should be at par with at least general medicine in the institution. And as part of the medical floor, as they have got neurology units and other units, we should have neonatology units. So that is how I think we would be really providing more personnel for neonatal care. So neonatal sepsis being a major public health problem, especially for low and middle end countries like Pakistan, there is a need to address the challenge at all levels, including prevention, clinical care, and judicious use of antibiotics, and follow-up of these babies in the short term as well as the long term, because in the long term, they have got adverse neurodevelopmental outcome. So with those few words, I would thank you, and I would end up with the verse of Iqbal, नहीं है नाउमीद इकबाल अपने किश्त वैरान से, जरा नम हो तो ये मट्टी बड़ी जरखेज है साथ में.